Dr. Gyani, I think there is a message from Dr. Unni. He's not able to join as panelist.
Yes, sir. Asmita, can you look into it?
I've joined now. I'm here.
You can start.
Oh, that's
What time are we starting?
Ma'am, you can start.
okay. So we are briefly discussing regarding the Indian Thyroid Society, the current position and activities. So after that, we're starting at 8 o'clock, sir. So good evening, one and all, and a very warm welcome. So before we start off with the Thyroid Clinics webinar, let us go through the journey of the Indian Thyroid Society, its current positions and activities. So Indian Thyroid Society was established and registered in 2003. It's a national body of healthcare professionals with special interest in thyroid disorders. It includes endocrinologists, endocrine surgeons, nuclear medicine physicians, general surgeons, and ENT surgeons. ITS is a member of the Asia-Oceania Thyroid Association, that is the IOTA. ITS currently has nearly 2,000 members. So the Indian Thyroid Society, the executive committee members of the Indian Thyroid Society are the founder president, Professor R.V. Jaikumar, and the current president, Professor Sarita Bajaj, madam. So included in the executive committee is the past president, Professor Rajesh Rajput sir, secretary, Dr. Arun Menon sir, and treasurer, Dr. Mini G. Pillai ma'am. Also, the vice president is Dr. Himagirish K. Rao sir, the scientific committee coordinator is Dr. Pramila Kalra madam, and the joint secretary is Dr. Sujoy Ghosh sir. Also included in the executive committee members is Dr. Shashank Joshi sir, Dr. P.K. Jabbar sir, and Dr. Krishna Sheshadri sir. So Dr. Mohammad Riaz, Dr. Sushil Gupta, and Dr. Ashraf Jani are also members of the executive committee. So the aims of the Indian Thyroid Society is to organize academic activities for healthcare professionals, to promote public education and awareness about thyroid disorders, to encourage research in thyroidology, to encourage public in our flagship journal, that is the Thyroid Research and Practice, to have state-of-the-art publications, to award fellowship of the society, and to encourage membership of the society. So the ongoing activities of the Indian Thyroid Societies are to have CMEs, updates, symposia, and conferences. Also, the thyroid clinics are being held weekly and fortnightly also. So previously it was weekly, presently it's fortnightly. So included in thyroid clinics are the journal club, the case conversations, monologue, dialogue, panel discussion, meet the professor session, quiz, workshop, and CPCs. So the other programs organized by the Indian Thyroid Society is the Thyroid Awareness Week, which has been celebrated between May 22nd to May 28th, the World Thyroid Day, which is celebrated on May 25th, and the Thyroid Awareness Month, which is celebrated annually in the month of January. So coming to the research activities of the Indian Thyroid Society, ITS provides annual grants for original research studies focused on thyroid and related disorders, preferably in the Indian context. The research grants are available, and to apply, the details can be accessed in the following website, that is the indianthyroidsociety.in. So coming to the Indian Thyroid Society journal, that is the Thyroid Research and Practice, it's being published twice a year in print and online. It has a quick turnaround time with the electronic copies available ahead of print. Coming to the fellowship which has been awarded by the Indian Thyroid Society. So to be awarded, it is basically to be awarded to the ITS members with expertise and experience in the field of thyroidology. It will be selected by an expert panel. The eligible members will be conferred Fellow of the Indian Thyroid Society. So Indian Thyroid Society has publications also. It's been, the first publication is the ITS Clinical Manual of Thyroid Disorders, which is of the first edition. Numerous guidelines have also been published, that is the thyroid dysfunction in pregnancy, the guidelines for the management of thyroid dysfunction during pregnancy, hypothyroidism, and diabetes. The other guidelines published by the Indian Thyroid Society are the consensus statement on the management of subclinical hypothyroidism, guidelines for the management of dyslipidemia and thyroid dysfunction, guidelines for the management of depression and thyroid dysfunction. So the upcoming publications of the Indian Thyroid Society include the ITS Clinical Manual of Thyroid Disorders, that is the second edition. The chief editors are Dr. Sarita Bajaj Madam and Dr. Rajesh Ratput sir. So the upcoming guidelines will be published in the year 2022 and 2023, which include management of subclinical hypothyroidism, management of thyroid disorders in pregnancy, and management of thyroid carcinoma. So the Indian Thyroid Society, the website link is indianthyroidsociety.in. It includes contents like the link to guidelines. It has access to ITS journal. It has records of all the academic events. Also, the online membership portal is also available on this website. So coming to the membership awarded by the Indian Thyroid Society, all MCI registered model medical practitioners in India are eligible to become life members. There are two types of life membership available. One is the full-time life membership. Basically, it is awarded for specialists in the field of endocrinology, endocrine surgery, and nuclear medicine. Associate life membership is awarded to all the other registered medical practitioners. So the applications for the membership is invited online. It is present on the ITS website. The details can be accessed on the following link, that is the indianthyroidsociety.in. Thank you.
Are we live now or are
So
we live now?
Hello, Winnie. Yeah, we're live. We're live.
Okay.
We'll start exactly at 8. This was just an introduction about the society, which we do as a routine for every meeting.
Well, I'm happy that the society is doing so well.
Oh, yes. Of course, you are the flag bearer, the initial flag bearer. And I think you brought it up to a very, I think, a very good level. And it's been maintaining that level, thanks to your work and, of course, Dr. Jayakumar as well.
Well, I remember being the secretary and making that logo, and also that being the first executive editor of the journal. Well,
Yes, about 2 decades, right? It's almost 2 decades. 2003. Good evening, Dr. Dev. Good evening.
So how is can you guide us on the flow? Would you like me to introduce only the chairperson who will introduce the speakers, or would you like
the
me
other
to...
way around? Ganvi, can you go through that, please?
Yes, ma'am. So, sir, I'll be first introducing Dr. Mala, ma'am, and Dr. Mala, ma'am, will be introducing you, sir. So then you will have to introduce Dr. Uma, ma'am, and Dr. Narendra Kotwal, sir. And then Dr. Mala, ma'am, will introduce Dr. Pranab Dev, sir.
Okay. Okay, sure.
And you will moderate the entire session. And then I think Mala will close at the end.
Yes.
Hello, everyone.
Hello.
Hello, Pramila.
Hi, ma'am.
I think everybody is there. Dr. Uma is there. Dr. Narendra. Good evening, Narendra.
Good evening, ma'am.
I think you were the first one to log in, unless it was Gandhi.
Well, as usual, army person should be there before time.
Today we have a strict discipline. So Jabalpur it is, right?
Yes, ma'am, that's right.
So how many
Oh, are you
years
in
now?
Jabalpur now?
Yes, Dr. Oni, I'm at Jabalpur.
Oh, good.
Yeah. I think almost 2 years or more
Oh,
or
ma'am,
less.
it's almost 1 year now. Already I'm panel for my next rank, ma'am. Somewhere in December, I should be moving out.
Okay.
Please.
Let me all take you all briefly through the quiz participation rules before we begin. So to participate in the rules, having the Zoom app on your mobile device or laptop is essential. You are requested to use a laptop for the ease of experience. The quiz will run for about 10 minutes. There will be first 2 dummy questions followed by the actual quiz. The quiz master will display the case or description of the question by screen sharing PowerPoint file. Participants should use the polls option to participate in the quiz. All 10 questions will be available when the poll is launched, and answer for all the questions is to be submitted at once at the end of 10 minutes. So to read the case or description, you can close the polls after you read it using the X button, and again use the polls option to answer the respective question. So IT team, can we have the dummy questions?
Yes.
So question number 1, in which city is Taj Mahal located? Option A, Chennai, option B, Mumbai, option C, Agra, and option D, Bangalore. So question number 2, how many oceans are there? Option A, 8, option B, 5, option C, 6, option D, 7. I hope all the participants could log their answers for the dummy questions.
So we will repeat this just before the quiz starts as well, right? This is just
yes, ma'am. This will be
rehearsal.
Yes, ma'am.
So we have 2 minutes to go live.
Yes, ma'am.
Ashmita, can you show us today's program, please?
Should I start?
I think we have a minute.
Yes, ma'am. Okay.
Yeah, please start.
Good evening, one and all. We welcome you to another episode of the Wednesday Special Thyroid Clinics. So the conveners for the Indian Thyroid Society webinar are as follows. Our esteemed ITS President, Professor Sarita Bajaj Madam, Dr. Pramila Kalra Madam, who is the Scientific Chair of the Indian Thyroid Society, Dr. Mini G. Pillai Ma'am, who is the Treasurer, and Dr. Anun Menon Sir, who is the Secretary of the Indian Thyroid Society. So in today's program is quite different from what it was before. So today's session, we have the CPC, apart from the quiz and the monologue. So it is actually my extreme pleasure to share the platform with my 2 mentors, that is Dr. Pramila Ma'am and Dr. Mala Dharmalingam Ma'am. So today's session will be chaired by Professor Dr. Mala Dharmalingam, and then the session will be moderated by Dr. A.J. Unnikrishnan Sir. The CPC session will be carried forward by Major General Dr. Narendra Kotwal Sir and Dr. Uma Nahar Ma'am. This will be between 8 to 8:40 p.m. So this is followed by the quiz by Dr. Pranab Dev Sir between 8:40 to 8:50 p.m. This will be followed by the monologue by Dr. Pranab Dev Sir, that is the FNAC Thyroid. So answers for the quiz questions will be discussed in the end following the monologue. And this will be followed by the announcement of the quiz winners. So we will start off this session with the introduction of the chairperson, Professor Mala Dharmalingam ma'am. So it gives me immense pleasure and privilege to introduce my mentor and guide, Professor Mala ma'am. Mala ma'am is presently the director and head HOD of the Department of Endocrinology of Bangalore Endocrinology and Diabetes Research Center. Ma'am is the ex-senior professor and HOD of MS Ramaiah Medical College and Hospital. Madam has MD Medicine, FDiap, and also DM from AIMS to her credit. Ma'am also has FAMS and FAC to her credit, FACE to her credit. Ma'am has about 136 articles published in national and international journals. And ma'am is also the ethical committee member of the prestigious ICMR. So ma'am has numerous awards also. Ma'am has received about 14 awards, including Apicon 85 Award, the BC Roy Award, the Most Inspiring Doctor Award, the Vocational Excellence Award, and the Paul Harris Award. Madam has about 12 orations, the prestigious MMS Ahuja oration, Sam GP Moses oration, PN Shah oration, JS Bajaj oration, presidential oration of the KR SSDI, and other numerous orations. So, Madam, I would like to you to introduce Dr. A.J. Unnikrishnan, sir. So, over to you, ma'am.
I don't think Mala is there.
Yeah, ma'am is not there actually.
So I think can we go ahead and introduce Dr.
Yeah.
Unnikrishnan?
Yeah.
Yes.
Yeah. Can I have sir's CV, please? So sir is currently the endocrinologist and CEO of the Chellaram Diabetes Institute, Pune. Sir has has finished his MD Medicine, DM Endocrinology, DNB, and also sir has MNAMS to his credit. Sir has numerous publications. He has published the largest multi-center study of subjects with pancreatitis and pancreatic diabetes worldwide, in addition to his more than 200 PubMed index publications. Sir has edited various journals like the Indian Journal of Endocrinology and Metabolism and Journal of Thyroid Research and Practice. Sir is presently the editor-in-chief of the journal, that is Chronicle of Diabetes Research and Practice. Sir has numerous awards. Sir has received the Jacob Memorial Prize for the best patient care during his MD in CMC Vellore. He has also received awards from organizations like RSSDI, the Diabetes Association of India, and the Endocrine Society of India. He has received 9 awards and also orations over the last 9 years, including the DTech Award for the Excellence in Diabetes and Technology in May 2022. Sir is presently the endocrinologist, the chief endocrinologist and head of the Chellaram Institute, Pune. So, sir, I would like you to introduce Dr. Narendra Kotwal, sir, and Dr. Umar, madam, to proceed with the CPC.
Well, thank you for that kind introduction. I still remember the Indian Thyroid Society in its early days when I was treasurer, secretary, the founding executive editor of the journal, and used to go for meetings with Dr. Jayakumar year after year. And now I'm here after a very long time on the virtual stage. I'm honored to be here. So let me begin by introducing Dr. Narendra Kotwal, very close friend, a gentleman, an officer and a gentleman, a very senior officer and a gentleman, I might like to say. He is, of course, a well-known endocrinologist, has several publications in national and international journals, is the member of the expert group of the ICMR task force in endocrinology. He's also been the organizing secretary of the National Conference of the Endocrine Society of India, the vice president of the Endocrine Society of India, secretary of the Indian Thyroid Society, has been a reviewer for the Armed Forces Medical Journal, is a wonderful gentleman, great sense of humor, great company, and excellent scientific knowledge. I have the highest regard for him. So he's going to speak after me. And of course, we have Dr. Uma Naha Saikia, who's a professor at the Department of Histopathology at the PGI, Chandigarh. She has several publications, 310 international publications and 59 national publications, has won awards including the national and international in cardiovascular research and dermopathology, has special interest in dermopathology, endocrine pathology, has been a member of leading associations, the Indian Society for Heart and Lung Transplantation, societies for dermopathology, the National Academy of Medical Sciences, and several other societies in what has been a truly illustrious career. And then we have the quiz at the end. Now, may I request Dr. Narendra Kotwal and Dr. Uma Naha Saikia to take over the proceedings and lead the baton from here. Over to you, illustrious people, and great to be with great people like you.
Thank you, Dr. Uni. Is my screen visible?
Hello?
Yes,
Not yet.
Yes, sir. So
Screen
am I
is
audible
visible, sir?
to you all?
Yes, you are.
Yeah. Thank you, Dr. Uni. At the outset, I'd like to thank Professor Sarita Bajaj to give me this opportunity. Well, CPC is always a learning experience, and I enjoy doing CPCs. So, ma'am, is my screen visible?
Yes,
Yes,
sir,
it is.
visible, sir.
Okay, fine. So this is a story about a 28 years male. He's a resident of Punjab. He was admitted on 11th of April 15 in PGI Chandigarh, and unfortunately he died on 13th of April. I'm not able to forward my slides. So this patient was admitted with difficulty in speech of 5 days duration, weakness of all limbs 1 day, and respiratory distress of 1 day. In the background history, patient had history of recurrent attacks of weakness of all 4 limbs since 8 months. Recurrent attacks. These episodes were sudden onset, preceded by vomiting associated with slurring of speech and transient retention of urine, which used to last about 1 to 4 days. And he was managed in local hospitals conservatively. In January 2015, he was admitted at PGI Chandigarh with similar episodes of pure motor quadriparesis, involvement of neck, truncal, and respiratory muscles. He was intubated for airway protection and managed conservatively. On evaluation, his potassium was 4.8 and TLC was high. CSF analysis was normal, and the contrast and has an MRI, brain and spine was normal. This time, as I told you earlier, there was a difficulty in speech of 5 days duration in form of slurring of speech, insidious onset, and rapidly progressed to complete loss of speech. Limb weakness of 1 day duration, sudden onset started in lower limbs, associated with heaviness and pain in thighs and calves. Rapidly progressed to involve upper limb, truncal, and respiratory muscles, and it was preceded by multiple episodes of vomiting. History of weight loss with preserved appetite was there. No history of wasting, fasciculation, band-like sensation of walking or cotton wool-like sensation. This history is just to rule out radiculopathy, neuromuscular junction, lower motor neuron problems. Then there is no history of bladder ball involvement, no history of diplopia, blurring of vision, dysphagia, no history of back pain or fever, and no history of heavy carbohydrate intake or substance abuse. Past history, no history of hypertension, diabetes, tuberculosis, epilepsy, surgery, trauma, blood transfusion, and he was a vegetarian. No history of drug addiction or any drug abuse. Family history, nothing significant. On examination, patient was conscious but agitated. GCS, he was E4. Since he was intubated, and M6. He had a hypotension and was on vasopressors. Pulse 128 per minute regular, and he had tachypnea, and he was afebrile. No pallor, clubbing, lymphadenopathy, pineal edema, cyanosis, icterus, and JVP was not raised. Respiratory system, crackles present our right mammary and inflexury area. CVS, PA abdomen was normal. Patient CNS agitated. Other things were normal. GCS was, as I told you, bilateral pupil 3 mm reactive to light, and tone was decreased in all 4 limbs. If sensory and cerebellar system could not be evaluated, or if you see upper limb, proximal distal was grade 4/5, hip flexion was decreased 3/5 and extension was 4/5. Ankle flexion and dorsiflexion was 4/5 and knee flexion was markedly decreased 1/5. And this patient had a hyperreflexia. You see all biceps, triceps, supinator, knee, ankle, there was hyperreflexia. In the investigation, you see 28 years old male, he has HB 10.7 and 10.12 reports, and last report is 12.4. He had thrombocytopenia, TLC was marked at the admission only, and peripheral blood smear was normocytic, normochromic, and platelets were reduced. Sodium was on the higher side of normal. He had a hypokalemia. On admission 2.1, subsequently 3.2, and I will show you multiple ABG reports where there are potassium reports. Urea was 44, which is slightly on higher side, and creatinine is 0.8. If we see urea creatinine ratio, it is more than 20. That means there was an intravascular volume depletion. Then look at the creatinine. Creatinine is gradually increasing from 0.8 to 1.1 and 1.9. That means this patient is going towards acute kidney injury. One report, calcium, I'm not sure about this calcium report, whether this was creatinine report. Calcium can't be 0.8, but it is there in the protocol. And subsequent report is 9.9. Here I'd like to point out that if you look at the serum albumin, it is 1.79. That means corrected calcium will be somewhere more than 12. So if patient had hypercalcemia. Uric acid was high. Patient had hyperphosphatemia, transaminitis, ALP was also high, and albumin is just 1.79. LDH was high, and CK-NAC right from the beginning was on the higher side. You look at the ABG, pH is 7.1, PCO2 is 41.9, and bicarb is 14. So this means this patient had metabolic acidosis and respiratory acidosis. And look at the potassium. Potassium is just 1.47. So at the treating unit, oral and IV potassium was started, and there was a dramatic improvement in the muscle weakness. It improved, but however, you see after about 11 hours, potassium is 7.38. So anti-potassium measures had to be instituted, and subsequently, if you see, then again, somewhere after about 10 hours, there is a hypokalemia, 1.47, then again 1.8, and then hyperkalemia. So this patient had a fluctuating potassium levels from hypo to hyper to hypo to hyper. And in the ABG, in the later part, you see there's an increase in PCO2. So that was attributed to endotracheal tube blockage. Urine routine examination is normal, but please note, pH is 6. Patient is having metabolic acidosis and pH is 6, which is not normal. Urine myoglobulin is high. CSF is normal. TSH is markedly decreased. T4 is very high. I don't have access to radiographs, but whatever report is there, that there's a patchy opacity in right lower zone. Ultrasonography abdomen, liver was 14.7. Prominent hepatic vein and IVC. Mild ascites, mild right pleural effusion, and kidneys were normal. Compression ultrasonography was normal. So patient course and management in PGI, 28-year-old male with recurrent history of recurrent acute flaccid paralysis, presented with history of acute flaccid quadriparesis with involvement of neck, truncal, and respiratory muscles, preceded by multiple episodes of vomiting. This is important to note. There were multiple episodes of vomiting. On evaluation, he had hypokalemia, respiratory and metabolic acidosis, TLC was high, chest X-ray patchy opacities, and CSF was normal. In view of poor respiratory effort, he was intubated. Oral and IV potassium supplementation was started, following which muscle power improved. In view of raised TLC and patchy opacity, possibility of aspiration was kept, and he was started on injection piperacillin, tazobactam, and clindamycin. Shock was managed with IV fluids and inotropic support, noradrenaline and vasopressin. I could not get anywhere in the protocol whether steroids were exhibited or not. Repeat potassium was 7.38. And corresponding ECG showed VPCs followed by VT. Immediately anti-hyperkalemic measures were started, resulting in resolution of VT. However, patient again developed weakness. Potassium was 1.47. In view of fluctuating potassium levels, patient was started on oral potassium supplementation with close potassium and ECG monitoring. That time, endocrine consult was taken, and patient was put on carbimazole and beta blockers. Despite these measures, his general condition and shock did not improve, and unfortunately, he died at 7:53 a.m. on 13th after almost 48 hours. So, unit's final diagnosis was hypokalemic periodic paralysis, thyrotoxicosis, thyroid storm, rhabdomyolysis, hypokalemia, query sepsis, thyroid storm, aspiration, pneumonia, sepsis, refractory septic shock, DIC, AKI, and cardiac arrhythmias. So we have a 28 years male with flaccid ascending weakness of 5 days duration with preceding similar recurrent episodes with full recovery. Now presented with additional respiratory failure with low respiratory tract infection requiring ventilation in a state of shock, requiring inotropic support. So whenever a patient of acute flaccid paralysis comes, what is the four-tier diagnosis? Functionally, acute subacute flaccid quadriparesis with involvement of buccal muscles and muscles of respiration. Physiologically, lower motor neuron and below means that neuromuscular junction are the muscles. Anatomically, it could be neuromuscular junctions, myopathy or radiculopathy. Etiologically, myasthenia gravis, polymyositis, periodic paralysis, or channelopathies. That is how we approach acute flaccid paralysis. And what are the causes of episodic generalized weakness? Electrolyte disturbances, like in our patient, hypokalemia, then muscle disorders like channelopathies, like periodic paralysis, or metabolic defects of muscles, neuromuscular junction disorders, CNS system disorders, which are unlikely in this patient, and lack of voluntary effort, which is not there in our patient. So differentiate between myasthenia gravis, polymyositis, and hypokalemic. This patient fits into hypokalemic periodic paralysis as limbs were more than the trunk. Onset was minute to hours, and it was a recurrent problem. So our patient had a hypokalemic periodic paralysis, no doubt, and he improved by potassium replacement. Then patient had a rebound hyperkalemia requiring anti-hyperkalemic measures. Now, patients of hyperkalemic periodic paralysis, basically potassium deficit is hardly any. There is a transcellular shift. Potassium is going from outside inside the cells, and treatment is aimed at just correcting the potassium levels, not correcting the potassium deficit. Slight correction in the potassium is sufficient to reverse the muscle depolarization and improvement in the muscle weakness. But 40 to 70% of the hypokalemic periodic paralysis patients do have this rebound hyperkalemia. Then paradoxical hypokalemia, we have seen subsequently patient had while on treatment, potassium was 1.7. This is a known thing which occurs in 25% of the patients of hypokalemic periodic paralysis. And usually patients who have severe thyrotoxicosis or severe adrenergic activation, they have paradoxical hypokalemia and they require higher doses of beta blockers. Does our patient have thyroid storm, as was a diagnosis made by the unit? If we look at the work and Watowski point scale for diagnosis of thyroid storm, one of the cardinal features of thyroid storm is high fever. Fever, in fact, our patient was afebrile. His pulse was around 128, so 15 score. Then I told you, he presented with multiple episodes of vomiting at the onset, so 10 score, and mild agitation. So it comes around 35, which comes in the category of impending storm. But if we look at did this patient have heart failure? Ultrasonographic report is showing dilated hepatic vein and dilated inferior vena cava, which happens once there is back pressure. Back pressure will occur once there is a CCF. So possibly if you take that into account and give 10 marks here also, then score is 45, then probably this patient had thyroid storm as per Burke's Watowski scale. What about Japanese Thyroid Association diagnostic criteria? As per this patient had thyrotoxicosis, restlessness, and vomiting. He fits in the diagnosis of thyroid storm. So overall, our patient presented with vomiting at the onset. He was agitated, dilated hepatic vein and IVC, transaminitis, increased bilirubin, hypoproteinemia, increased calcium, and TFT markedly deranged. So it qualifies for the diagnosis of thyroid storm. Now, is it possible that thyrotoxic periodic paralysis and thyroid storm, they present together? This is a case report from India only, where patient of Graves' disease presented with periodic paralysis also and thyroid storm. So it is possible to have both things together. Then our patient had a marked hypokalemia. Now in periodic paralysis, generally ABG is normal. And in our patient who presented with persistent vomiting, I would have expected metabolic alkalosis, but patient had a metabolic acidosis. And since chloride values are not there, I'm not able to tell you whether this is high anion gap or normal anion gap acidosis. Nonetheless, whenever there's a metabolic acidosis, it can happen with the hypokalemia. If there is a GI potassium loss, there is no history of any gastroenteritis, then it can occur with Diabetic ketoacidosis, amphotericin B or acetazolamide, no such history is available, and I presume sugar is normal. However, report is not there. Then it can happen in renal tubular acidosis. So our patient had hypokalemia and acidosis, and it's likely that patient had renal tubular acidosis. Is it possible that renal tubular acidosis and hypokalemia presenting for the first time together? Case have been reported, but some of these patients had a underlying autoimmune disorder like Jordan syndrome. So what about our patient? There are case reports, thyrotoxicosis leading to renal tubular acidosis presenting as periodic paralysis, as was this case presented published in International Journal of Clinical Endocrinology and Metabolism, and another case where thyrotoxic and renal tubular acidosis were present in a patient of Graves' disease. So it is possible to have thyrotoxicosis and renal tubular acidosis, and once we reverse the thyrotoxicosis, renal tubular acidosis improves. Then our patient had a refractory hypotension. Now, possibly patient had a hypovolemia, recurrent vomiting, and septic shock was the cause of refractory hypotension. Then is it cardiogenic? As I told you, dilated IVC and hepatic vein and thyroid storm leading to CCF, maybe, may not be there. Difficult to say, because initially at the time when patient presented, there were no bilateral basal clefts. So unlikely, and patient had shock at the onset only. So it's likely septic shock. What about adrenal insufficiency? No, thyroid storm patients are known to have adrenal insufficiency. And as I told you, there is no available history where the patient has exhibited steroids. Possibly he might be having adrenal insufficiency, but however, point against is that sodium is slightly on higher side, 143, 142, and there is a hypokalemia, and there are no telltale signs of adrenal insufficiency except for the hypotension. So hypotension most probably in this patient was due to septic shock. Septicemia, no doubt this patient had septicemia. There's a leukocytosis, thrombocytopenia, patchy opacity, chest X-ray, possibly pneumonia, transaminitis, hypotension, which all led to AKI. Then, as I told you, this patient had anemia and hyperproteinemia. So what is the cause? Patient has been having recurrent episodes for last 8 months, and he was a vegetarian. Probably it was a nutritional. Was it due to chronic liver disease, anemia and hyperproteinemia? Ultrasonography, liver is normal. So unlikely due to CLD. Then nephrotic syndrome, urinary is normal. So it's not because of nephrotic. Protein losing enteropathy, there is no history available. But however, suppose patient has underlying Graves' disease associated celiac, it may be possibility, but seems unlikely. Chronic inflammation, unlikely since appetite was preserved and in fact was increased. So anemia and hyperproteinemia is likely due to nutritional in this case. Rhabdomyolysis, yes, this patient had rhabdomyolysis. There is increased creatine kinase, NAC, hypercalcemia, hyperphosphatemia, hyperuricemia, increased LDH, and increased urine myoglobin. So a word about hypokalemic periodic paralysis, incidence and sex distribution. In Asian population, 2% of the hyperthyroid patients have this, and male to female ratio as in Japan and China, 17:1 to 20:1 Japan, and China is quite high. This is the Indian experience of thyrotoxic periodic paralysis. 52 patients of hypokalemic periodic paralysis, out of which 17.3 had thyrotoxic periodic paralysis. And in them, general mean age was 36, male to female ratio was 8:1. This is a publication from our centers where 15 the patients had thyrotoxic periodic paralysis over a period of 5 years, 32 episodes, and mean age was slightly lower, 30.6 years. So amongst the pathogenesis, why it occurs? Basically, sodium potassium ATPase activity is increased. So it allows potassium to go from outside cell to inside the cell, and which is triggered by the either insulin, androgens, catecholamines, thyroid hormones. Or there is a potassium efflux from the myocytes is decreased because of the decreased activity of KIR channels, which is again affected by insulin, catecholamines, and inactivating mutation. So hypokalemia leads to paradoxical muscle depolarization, sodium channel inactivation, and muscle paralysis. So generally, it's a male predominance is there. Presentation is 20 to 40 years. Periodic flaccid paralysis of proximal muscles, many lower extremities, negative family history, maybe a hypertension may be there, and there may be subtle clinical features of hyperthyroidism. It may not be florid. And this is just to show that patients' thyrotoxicosis can be due to any cause. Then genetic susceptibility and precipitating factors all lead to thyrotoxic periodic paralysis. And laboratory hallmark is raised T4, low TSH, and hypokalemia. No, if we analyze the unit diagnosis, hypokalemic periodic paralysis, yes, definitely it was there. Aspiration pneumonia, yes. DIC, I don't think it was there because there is no evidence of coagulopathy, and PBS doesn't show any fragmented RBC. AKI, yes, it was there. Cardiac arrhythmia, hyperkalemia induced, yes. Thyrotoxicosis, yes. And thyroid storm, as I told you, as per the Japanese JTA and other criteria, it was there. See, whenever there's a CPC, straightforward cases are never presented. I was just thinking, is there anything, something else? Moreover, is endocrine CPC. So I was just thinking, the clinical protocol does not suggest in any way, but still, just loud thinking, anemia, hypoproteinemia, hypercalcemia, and opacity in the lung. Could it all be paraneoplastic manifestation of underlying neoplasm, maybe neuroendocrine tumor? I don't know. Clinical protocol doesn't support this, but however, as I told you, this all autopsy, whenever autopsy is done, and these are great learning and humbling experiences for clinicians. I'm sure Dr. Uma will tell us something more about it. And cause of death in this patient was, of course, hyperkalemia-induced arrhythmia. So that is all from my side, and I would like to sign off by message from this young one.
Thank you, Dr. Kotwal, for that wonderful presentation. And now we'll have Dr. Uma has already been introduced. So to Dr. Saikia for the next part of the presentation, unless there are some questions from the audience or from the other panelists. We can have the discussion after that.
First of all, Dr. Unni, am I audible and visible?
You are, ma'am.
Unni, there's one question from Dr. Pranab.
Okay. Is there?
In
Lovely.
the chat box.
Very nice.
So, question to Dr. Kotwal. How do you explain urinary retention in this patient?
So since patient was in the shock, so that must be the reason of the retention. And there is a muscular weakness. So all over there's a muscles are weak. That can explain the retention.
Dr. Kotwal, can I ask a question?
Yes, sir. Yes, sir. Please, sir.
See, here, problem what I face is cause of death. Okay. You have speculated cardiac and other things. Unlikely thyroid storm has killed the patient. What is striking the whole cause of death, I feel, septicemia. Now, we have seen so many periodic paralysis, thyroid storm. Why did septicemia occur in this patient? Right? Now, septicemia led to all those things, finally death happened. So my question is, what is the underlying cause for septicemia in a patient? He may be having thyrotoxic so long, not detected. First time they present with periodic paralysis, that's what it is. So this one is clinically, before Dr. Uma tells us what was there in the postmortem, do you think we have a clue why this patient developed septicemia, and all subsequent things are a result of septicemia?
Sir, a very valid point, sir. Now, if you look at this patient presented with the slurring of the speech and later on the respiratory muscle weakness. So most probably he must have aspirated, sir. There must have been aspiration. So since there's a muscle weakness, that is what was the diagnosis. I feel it must have been some aspiration. And you said TLC is quite high in the beginning, and there's opacity. So most probably he must have aspirated.
I don't agree, because most of the patients who are presented with periodic paralysis are men, second and third decade, young, one thing. Second thing, they are conscious. Though they have quadriplegia, they are all right otherwise. It's not a bedridden patient who cannot take food having aspiration. So these are the patients who are taken to the hospital, within 24 hours, they go home. Right. Some people get repeated, second time periodic paralysis, all right. Why should a young man have an aspiration? Though there is quadriplegia, he is not unconscious. I don't find any reason why he should have aspiration. In this case, he is conscious, clear everything. I still cannot believe that aspiration is the cause of septicemia. There may be something else.
There could be, sir, quite possible.
That's all.
Can we move on, please?
I agree with that point. Am I audible first of all?
Yes, you are. Yes, you are.
Okay, so first of all, very many thanks to Dr. Sarita, and I congratulate her for taking this initiative. Thank you, ma'am. And I can see many faces over here, and I thank Dr. Unni and others for the kind introduction which they gave. though we are not having very illustrious career. We're simple people working at PGI, that's doing our best. And I must say that Dr. Narendra Kotwal, as usual, he's done a good job, an excellent job, I must say. But the query of aspiration, of course, did cross my mind also. Why was he talking about aspiration pneumonia? So let's see what the autopsy showed us. Just a sec. So, slide share, no? Okay. Is my slide visible?
Yes. I think slideshow.
Yeah, I'm going to the
slideshow.
slide. Yeah. So is that fine?
Yes, ma'am.
Okay. Am I audible properly?
Yes, yes, yes.
Okay. So now you've heard the history that this was a young male who basically presented with cardiac arrhythmias and hypokalemic periodic paralysis and had hyperkalemic related thyrotoxicosis. So this was a complete autopsy, and the prosectors on opening the serous cavity did yield, it showed excess of fluid, both in the peritoneal as well as in the pleural cavities. In the peritoneal cavities, it was straw colored. However, in the pleural cavity, it was relatively little blood mix. The pericardial cavity did not yield any excess of fluid. Now let's come to the heart first, because the patient had arrhythmias and had cardiac problems first. So this is the heart, which weighed around 323 grams. It is slightly overweight against the normal weight of upper limit of 300 grams. So if you see, this has a little globular shape and some increase in the epicardial fat is seen. And if you witness this, this is the right auricle, which is discolored and it felt very firm on palpation. So it was containing a thrombus. And this is the microscopic section from the thrombus. Yeah, so if you see this, this is the muscle of the right auricle, and this is the fresh fibrin thrombus, which is seen in the right auricle. This possibly could be because of the repeated arrhythmias which he was having. Some blood got dislodged there and turned into fibrin later, a thrombus later. There's some problem. Yeah. So these are the photographs which shows the right inflow tract as well as the right outflow tract. The inflow tract includes the right atrium and the right ventricle. And as we see, it appears little dilated, the right atrium. This is the smooth part and the rough part. However, the tricuspid valve is unremarkable. The right ventricle is also slightly dilated. However, there's no significant hypertrophy. When we focus on the right side, the outflow tract, there is dilatation of the root of the pulmonary artery. Some endocardial sclerosis in the right ventricle. The wall thickness, however, measured only 5 millimeters, which is slightly, you can say, borderline hypertrophy of the right side. This is the inflow tract of the left side, the left atrium, normal left atrium, and normal mitral valve with some age-related changes or hemodynamic changes which could be seen. However, the left ventricle wall measured around 1.6 centimeters, which was slightly hypertrophic. And this is the outflow tract of the left side, which shows normal aortic valve and aorta. There is no significant atherosclerosis either in the plaque or fatty streak stage. There is evidence of concentric left ventricular hypertrophy as well. Now let's see microscopically what the heart showed us. Now this is the section from the left ventricle taken from the cross-sectional view. And as we see here, there is patchy, mild to moderate interstitial fibrosis. For the age of 27 years, we do not expect any fibrosis within the myocardium. And the surrounding myocytes shows hypertrophy as well as accompanied atrophic myocytes. However, point to note here, there's no significant inflammation, no myocarditis or no neovascularization. And the coronaries examined were also near normal. There was no significant atherosclerosis in the coronaries. Now, if we see on a higher magnification, the atrophy of the myocytes and the hypertrophy of the myocyte is clearly visible with some nuclear anisonucleosis along with enlargement of the nucleus, along with interstitial fibrosis. And this fibrosis is highlighted on the Mason's trichome stain by this bluish color, which picks up the collagen and tells you that there's a significant amount of interstitial fibrosis in this heart, causing both myocyte hypertrophy as well as atrophy without any evidence of myocarditis, which can be seen in such patients. Now let's see the biopsy from the skeletal muscle. Because patient had periodic paralysis, we did examine the skeletal muscle. And as we see that the muscle fibers are maintaining their shape and the nucleus is placed periphery as normal. There's no inflammation or no rounding of fibers or no atrophy of the fibers, thereby telling us that morphologically this skeletal muscle was normal. Now let's go to the next organ, which is the kidneys. Both the kidneys together weighed around 220 grams, which is normal. The cortical surface and the capsule, after removal of the capsule, it was smooth. There was no scarring or any cyst. The aorta, the ureters were also within normal limits, and so was the bladder. When we examine the kidneys on a closer view, we see that the corticomedullary junction was distinct. There was no congestion or any focal lesion. And the aorta is also showing clean surface without any significant atherosclerosis. This is the microscopy what kidney looked like. The glomeruli did show some lobular accentuation. However, there was no increase in mesangial cellularity or any membrane thickening. In addition, if we notice that the interstitial compartment is also relatively normal, the tubules show degeneration of the cells. These are the proximal convoluted tubules, which shows the shedding of epithelium into their lumen, thereby suggesting acute tubular injury. And in other areas, the medullary areas, there was presence of these kind of granular to pale eosinophilic cast, which was positive on PAS, as highlighted on this pyruvic acid shift stains, and thereby suggesting that there was evidence of some rhabdomyolysis. These are not hyaline casts. Hyaline casts are usually very glossy, thick and opaque in color, and they are brightly PS positive, in contrast to these casts where they are irregularly PS positive. Now let's come to the thyroid, which the seed of pathology. Now before going on to the pathology, I would like to demonstrate the normal thyroid gland to the resident specially. We know that thyroid is a butterfly-shaped organ located in the anterior neck, and the normal weight of the thyroid is around 15 to 20 grams, which is relatively little more in males compared to females. However, in secretory phase of menstrual cycle, it is heavier in females. The weight increases in childhood and adolescent, and the right lobe is usually larger than the left lobe. Now, this is the lobar view where we see that the thyroid follicles are filled up with colloid, and on higher magnification, we see that there is low cuboidal to columnar follicular cells surrounding each thyroid follicle. So this is what the normal thyroid look like. Now let's see how this patient thyroid look like. This is the gross photograph of the thyroid. As we see here, the weight is 50 grams. So it is more than double the weight of the normal thyroid. It was very firm in consistency, and the cut surface shows loss of that mahogany brown color or the honey color of the thyroid, of the colloid, which should be seen in the thyroid follicles. It was very firm to feel, but there is no definite nodule formation or any capsular lesion which is noted in the cut surface or on the outer surface. Now these are multiple serial slicing which was done to the entire thyroid parenchyma, and as we appreciate that there is no nodule formation, it was rather very rubbery in consistency like a lymph node. No nodule or any capsule around any of these areas were seen. This is a low power photograph of one of the sections from the thyroid. As we see, the capsule is seen all around. And what we see is that the follicles are very much proliferative. There is absence of colloid in most of the follicles, and these follicles don't appear round and regular. They have this kind of honeycombing appearance. And if we see further on the closer magnification, we said that there are these micropapillary projections. When we say micropapillae, we mean that there is no fibrovascular core running in these projections. So these are called as micropapillae, happening all around in the thyroid, diffusely in all the thyroid follicles. And the thyroid follicle size is almost 3 to 4 times of the normal thyroid follicles. This is another higher part to appreciate this micropapillary proliferations within the thyroid follicles. There is scanty amount of colloid or no colloid in most of the thyroid follicles, and there is no nuclear stratification or any features of neoplastic pathology in this thyroid. Occasionally, the inspissated colloid was also seen, and you see that proliferative thyroid follicles with these micropapillae projecting into the lumen of the thyroid follicle. And another high part to appreciate the nuclear morphology, occasionally one could identify the mitotic activity, thereby suggesting that it's a highly proliferative lesion, but no significant amount of colloid or any nuclear stratification or any other neoplastic pathology was seen. One focus of lymphocytic infiltrate was also noted in this thyroid, which was also inciting a Hurley cell response in the adjoining thyroid follicles, which is just a reaction to this lymphocytic infiltrate, but there was no evidence of Hurley cell, significant Hurley cell change in the thyroid. And this is the adjoining parathyroid, which also shows relative depletion of the fat, but otherwise normal in morphology. So we know by now that there is no neoplastic pathology in the thyroid. What we are dealing with is with the florid follicular hyperplasia in the thyroid with micropapillary projections and scanty amount of colloid. So it did fits with the features of Graves' disease with hyperplastic follicles in the thyroid. Now, as there was history of, as the thyrotoxicosis is quite often related with adrenal insufficiency. So this is the section from the adrenal, which shows normal cortex and the medulla. There was no history of steroids in this patient given, whatever was available with me. And the adrenal showed normal morphology with no adrenalitis or any cortical hyperplasia. This is the section from the pancreas, the normal acini, the exocrine part and the endocrine part. These are the islet cells, which look little pale on the low magnification, and there's normal morphology of the pancreas. Now let's come to the complications which this patient had. Dr. Narendra did talk of aspiration pneumonia, but I'm afraid there was no evidence of aspiration pneumonia, but I would show what this lung held. So the lungs weighed 1500 grams, which is again overweight. Normally the weight should not be more than 7 to 900. The range is up to, the maximum limit is 900 grams. They were feeling consolidated more so in the bases and had a very rubbery consistency with patchy fibrinous tags. The tracheobronchial tree, however, was essentially normal. And this is the cut surface, which shows a clean tracheobronchial tree, no evidence of any inspissated mucus or aspiration, and the consolidation of the lower lobes, which was much more hemorrhagic and very firm to feel on palpation. Now, this is the section from the areas which were non-consolidated. Now, since this patient had left ventricular hypertrophy, though there was no significant right ventricular hypertrophy, but the intra-acinar arteries in the lung parenchyma were very prominent, and they did show evidence of medial hypertrophy with some degree of intimal proliferation, and adjoining parenchyma or the alveolar spaces showing some alveolar hemorrhage. And this is the elastic von Wiesen stain highlighting the fibrointimal hyperplasia and medial hypertrophy, suggesting pulmonary arteriopathy or features of pulmonary arterial hypertension. According to WHO, it fits with grade 1 to 2. Now, these are the areas which showed hemorrhagic consolidation. So, predominantly, there was evidence of this exudate in the alveolar spaces accompanied with pulmonary edema, as seen as pale pink material within the alveolar spaces. And the bronchial tree was filled with neutrophil-rich infiltrate, which was ulcerated and spilling into the adjoining lung parenchyma, causing confluent bronchopneumonia. A further high part to appreciate the type of inflammation, which was predominantly neutrophils with nuclear debris, some hemorrhages, and which is getting confluent, causing breakage of the alveolar septate. Other areas to appreciate alveolar hemorrhages and pulmonary edema, again, making this lung feel more firmer and heavy. In addition to that, the larger pulmonary artery did have a presence of fresh fibrin thrombus, as seen by this pinkish fibrinous material, granular material, which was confirmed by Marshall scarlet blue stain, where the fibrin takes up red color. Now let's move on to the next organ, which is the organ complex comprising of slice of liver, the C loop of duodenum, the pancreas, and the slice of spleen. The liver weighed 1390 grams and it was very firm to feel. The inferior vena cava was normal. There was no thrombus there, and so was the cut surface or the outer surface of the liver parenchyma. The pancreas was also essentially normal. The spleen was 270 grams and did not show any focal lesion or any infarction. This is the low power magnification of the liver, which showed a maintained lobular architecture. What we see here is that there were areas of this reddish and pink areas. This reddish areas represents hemorrhagic necrosis around the central zone. That is the zone 3. And the portal tracts are essentially normal, and so are the preserved hepatocytes. There is no fatty change or no evidence of any hepatitis. This is a higher magnification to appreciate this centrizonal hemorrhagic necrosis, which represents features of shock in this patient. There was no evidence of any portal tract inflammation or any lobular inflammation or any fatty change in this liver. Section from the spleen highlighted red pulp congestion with white pulp depletion. These are the areas of white pulp. And the remaining organs, including the stomach and esophagus, showed normal epithelium, but for congestion of the mucosa of the stomach. The small and the large intestine were also examined both grossly and microscopically and did not show any significant pathology. The bone marrow examined was normocellular for age with adequate representation of the hemopoietic elements, including the megakaryocytes, the erythroid, and the myeloid series. So, what would be the now? I was thinking of predominantly why this patient was having so many arrhythmias so often. Of course, we all know that when there are aberrations in the TSH levels or T3, T4 levels, they can give rise to arrhythmias. However, besides what Dr. Narendra has discussed, the cardiovascular complications in the Graves' disease, they are variable from dilated cardiomyopathy to myocarditis to arrhythmias or to thyrotoxic cardiomyopathy. And I found several literatures based on this features of cardiac related complications secondary to Graves' disease. And the largest series is from the Ukraine, which was published in 2015. And they found that thyrotoxic cardiomyopathy was seen in around 77% of these patients of Graves' disease, rather than having any myocarditis or other pathology in the heart. And in addition to that, there's a significant mutation, which is a potassium channel gene, that is KIR 2.6, is responsible for the thyrotoxic hypokalemic periodic paralysis. So maybe this patient harbored this gene mutation, although since we do not have the facility for this studying this gene mutation in our setup, I am not sure that this patient might be having this mutation. So as Dr. Narendra also highlighted, that the incidence of thyrotoxicosis, though it is higher in females, but it's the males, particularly in the Asian descent, which manifest this complication. So putting up everything together and knitting up, this patient did have Graves' disease, which led on to the thyroid storm. There was evidence of thyroid myopathy. Possibly patient might have harbored this genetic mutation. And this Graves' disease led on to thyrotoxic cardiomyopathy, causing respiratory distress, and thyroid myopathy can cause rhabdomyolysis. Hypokalemia was a cause of arrhythmia here, along with thyrotoxic periodic paralysis. And a combination of these caused cast nephropathy because of the rhabdomyolysis, and bronchopneumonia and pulmonary thromboembolism was the terminal event which led on to the death in this patients along with cardiac arrhythmias. So knitting up everything together, the final autopsy diagnosis in this patient, who was a 27-year-old male, had hyperkalemic related thyrotoxicosis with periodic paralysis, is diffuse thyroid follicular hyperplasia along with thyrotoxic cardiomyopathy, grade 1 pulmonary vasculopathy, confluent bronchopneumonia with septic thromboembolism, myoglobin cast nephropathy, and centrizonal hemorrhagic necrosis. So thank you for your time. Thank you so much. And thanks for giving me this platform to share this case with you all. This was an intriguing case because at the time of reporting also, we were debating whether we are dealing with a neoplastic pathology or just a florid diffuse follicular hyperplasia in the thyroid. Thank you, and over to you, please.
Well, that was a very fascinating.
I've answered your queries. Sometimes you don't need to show the surprises. I thought this is more for the DM residents, so better show them a classical pathology first.
Yeah, thank you, Dr. Uma. That was a nice case, but I really don't know whether clinically I could have made a diagnosis of cardiomyopathy given the clinical protocol, but it was nice to see the whole things.
That's why.
Thromboembolism did cross my mind, because thyrotoxicosis is a hypercoagulable state, but yes, probably I didn't think too much about that. And so as Prasanna sir told, that most probably it was the infection which killed this patient. So you have shown that infection ultimately killed the patient.
Yeah, possibly. Terminal bronchopneumonia. That was terminal.
Now, the important thing is two things. One, what is the test which could have diagnosed cardiomyopathy in this patient? Now we are wiser always. Second thing is there something we could have done better to prevent that death? These are the two issues in any CPC. So what would have been, according to you, the best marker for thyrotoxic cardiomyopathy?
Sir, I think maybe that time echo could have given us some clue. If echo would have been done, that would have given us idea, because this patient had a thickness, left ventricular mass thickness was also there. Probably that would have given us some idea what is the ejection fraction, what is the ventricle wall thickness, where these regional wall motion abnormalities are not. As far as the treatment is concerned, this patient was on the good cover of antibiotic. And maybe I think beta blocker initially, the patient was in hypertension, steroids, I feel, should have been exhibited.
Okay. But is there any blood marker for thyrotoxic cardiomyopathy apart from what we have seen?
So then we can do that. Markers like troponin MB can be done, sir, for the cardiac thing. Otherwise, echo, I think, is the modality we should have diagnosed, sir.
Because myocarditis, you will have a very high level of this one, troponin, rather than cardiomyopathy. Cardiomyopathy is not acute. My understanding, do you think it's an acute process, chronic process, which was there before? And do you think that is the one which has led to that? Do you think that he had many months of this thyrotoxicosis, cardiomyopathy, and septicemia, finally death?
So to say that there was okay. So to say that,
sorry, I interrupted you.
Please go ahead. To say that there is a left ventricular mass thickness, so thickness will not occur acutely. It has to be there for a longer duration.
Correct.
Yes.
Yes.
And besides, there was significant degree of interstitial fibrosis also with myocyte atrophy. So that also is a long-standing process. It doesn't happen just in a month or 2 months. It takes few months to happen.
Why does myocyte fibrosis occur? In diabetes, it's a totally different thing. CD147 is the one which induces cardiac myofibrosis. That is understandable. Even in animal experiments and humans, it has shown, if you measure the CD147, those who have got hyperglycemia, CD147 higher, leads to myocardial fibrosis. What is the pathology in thyrotoxicosis?
Sir, in diabetes, it is the microcirculation which is affected besides macrocirculation. So that causes interstitial fibrosis accompanied with atrophy and hypertrophy. Here, the question is of supply and demand. The demand is more, the supply is less. So there is patchy ischemia, and which leads on to fibrosis, and that fibrosis causes both hypertrophy and atrophy, thereby leading on to cardiomyopathy in later course of the disease.
Do you think patient should have gone into heart failure? If he has got cardiomyopathy,
that stage comes very late, sir. That really comes when the ejection fraction drops down to less than 50 or less than 45, I would say. Not before that. So we have seen,
You have a result. See, that means this patient did not have failure because he didn't have any symptoms. There is a cardiomyopathy going on even before, let us say, as Dr. Kotwal said, even if he had done echo, probably ejection fraction is not 20, 30 or anything because he doesn't have failure symptom. It could have been 60 or even more than that because in thyrotoxicosis, it's high output failure. So you will not see that it's a low output. Ejection fraction may be high.
I would address you that in these cases, it is not the echo which is much more helpful. It is the MRI which is helpful.
I agree with you. That's what I wanted to put. Probably you would have said MRI would have given you more of diagnosis at a cell level rather than echo could have been normal.
Yes, sir. Absolutely right. I agree with you.
Of course, we don't think of in a patient, if I or you are treating, we will not think of MRI, the condition was so bad. He cannot even go there. But retrospectively, we think probably that is the one would have given you better. But unfortunately, we got the information in postmortem.
But such patient like this coming to casualty, I think, as you said, MRI is the diagnostic modality, but echo will give us some idea. Some left ventricular mass thickness is there, not high output cardiac failure.
I disagree with you.
So how do you?
But I would like to say one thing that I'm really glad.
Dr. Umar, you tell me in echo, can't you measure the ventricular wall thickness?
We do. There was ventricular wall thickness, but when we talk of cardiomyopathy, especially the dilated type, when we talk of thyrotoxicosis, it is the dilated cardiomyopathy. The chambers are not really dilated here. So the EF is not going to be altered. If there's significant fibrosis is present, you might pick up. But if it is just started, maybe some months ago, you will not be able to pick up that on echo. That's why MRI is the answer.
Maybe we can ask.
Sorry, I think you mentioned troponin, but I think NT-proBNP may also
I was about to say that proBNP.
Because that indicates stretching of the cardiac myocytes. And even if the thyrotoxic high output cardiac failure is causing a normal ejection fraction, some sort of a heart failure with a normal ejection fraction still can be picked up by an NT-proBNP, and a combination of troponin and NT-proBNP, which will detect both ischemia and myocyte injury, might even be better. MRI, I agree, but in this situation, the clinical situation, I think it
was not possible to do.
It would be, in retrospect, it would be a good test, but in the middle of a patient becoming sick, probably the clinician would think of this as being a remote possibility and defer it. But I agree with you. We are always wiser in retrospect. It was wonderful listening to both of you and Dr. Bajaj.
Dr. Oni, last question and query. Dr. Uma, as a clinician, sometimes I feel it's baffling to make a diagnosis of alveolar hemorrhage in this patient, whereas initially a hemoglobin was 10 and later on hemoglobin was 12. In fact, in alveolar hemorrhage, one of the hallmark is there's a drop in the hemoglobin. So that was the point I thought that as a clinician.
That alveolar hemorrhage is secondary to the pneumonia. So as we know from pathology classes, the stage of red hepatization and white hepatization, gray hepatization, right? So that alveolar hemorrhage is part and parcel of the bronchopneumonia, not per se hemorrhage.
Okay.
Right? Yeah.
Dr. Mala Dharmalingam,
left atrium enlarged or not?
Left atrium was not really enlarged, sir.
So if atrium is not enlarged, cardiomyopathy, neither your pro-BNP, not your other things is going to help. And he has no symptoms of failure. So when you don't see cardiac enlargement, and if you don't have failure, why do you think pro-BNP is going to be high? It's not going to help you.
Right.
And pro-BNP is a marker for, it's a prognostic marker rather than a diagnostic marker.
Not diagnostic, only prognostic. Anyway, good we argue to disagree.
Yeah, no, it's a healthy discussion. CPCs are for discussion.
Yes, we all become wiser, right? When all of us agree, there is no the knowledge. If all of us disagree, then only we see that
we agree to disagree.
Yeah, we agree to disagree. Thank you very much.
Thank you. Thank you all for the time and patience.
Professor Mala Dharmalingam, madam, your views. I think you're muted.
Ma'am, you're not audible.
You are mute.
So that was, thank you so much, Oni, and thank you for doing a great job. The presentation was excellent and the discussion was great to watch. But what was very intriguing for me is this person, young man, comes with hyperthyroidism, hypokalemic periodic paralysis, and the end of the cause of death, as per Dr. Kotwal, is hyperkalemic fibrillation with possibly thrombus formation and death. So this is something which I want to tell the youngsters, that aggression is important, but it should be careful aggression, not over-treating, causing, I think, hyperkalemia, causing a fibrillation, causing a thrombus discharge. Cardiomyopathy must have been there. The heart was, already myopathic. So obviously a little of strain made it into go into fibrillation, throwing out a thrombus. So many a time we think that endocrine problems are, it's a simple problems. When these acute problems come, they need to be aggressively managed, but with careful supervision so that we don't induce problems in them, like causing hyperkalemia in this particular patient. But I think otherwise a beautiful and a very good session.
Over to Dr. Kanavi.
Yes, sir. So thank you, Dr. Ma'am, Unikrish sir for more session, and Dr. Bala ma'am for chairing the session. So as Madam could not join due to technical reasons, let me introduce Madam now. So who's the chairperson for today's program. So Madam is presently the Director and HOD of the Department of Endocrinology, Bangalore Endocrinology and Diabetes Research Center. She's the Senior Ex-Professor and HOD of Ramaya Medical College and Hospital. Madam has MD, FDIAB, DM, FAMS and FACE to her credit. Ma'am has about 136 articles in national and international journals. Madam has numerous awards to her credit, like the Apicot Award, the BC Roy, the Most Inspiring Doctor, the Vocational Excellence, and the Paul Harris Award. Ma'am has also numerous orations, about 12 orations, MMS Ahuja oration, Sam GP Moses P. and Shah oration, JS Bajaj oration, the presidential oration of the KR SSDI, and numerous other orations. So, ma'am, moving on to the next session, that is the quiz, which might be quite different from the previous ones. I now request Dr. Mala ma'am to introduce Dr. Pranab Dev sir, who will be conducting the quiz. So over to you, ma'am.
Thank you, Dr. Ganavi, for the introduction, and I thank Dr. Sarita for the invitation for this very exciting program. And it's my pleasure to introduce the Dr. Professor Pranab Dev, who will be the quiz master for today. He's professor at PGI Chandigarh in the Department of Cytology and Gynecological Pathology. And his area of interest is FNAC, AI, and flow cytometry. He has a lot of publication. He has authored 12 books in cytology with more than 450 original publications in international journals. He's also the fellow of the Royal College of Pathology. He's member of International Academy of Cytology, and he's enlisted as top 1% researcher in pathology. Glad to welcome you, Professor, and over to you to take the session forward.
So let me brief you all regarding the quiz participation rules again. So to participate in the quiz, having a Zoom app on your mobile device or laptop is essential. You are requested to use a laptop for the ease of experience. The quiz will run for about 10 minutes. There will be first 2 dummy questions followed by the actual quiz. The quiz master will display the case or description of the question by screen sharing a PowerPoint file. The participants should use the polls option to participate in the quiz. All 10 questions will be available when the poll is launched, and answer for all the questions is to be submitted at once at the end of 10 minutes. To read the case or description, you can close the polls using the X button and again use the polls option to answer the respective question. So can we have the dummy questions, IT team? The IT team?
Yes, ma'am.
So number 1, in which city is Taj Mahal located? Option A, Chennai, option B, Mumbai, option C is Agra, and option D is Bangalore. Question number 2, how many oceans are there? Option A, 8, option B, 5, option C, 6, and option D, 7. So I hope all the participants can log their answers. Over to you, sir, now to conduct the quiz. So you can share your screen.
Can I share the screen?
Yes, sir. Yes, sir. Yes, sir.
Am I visible?
Yes, sir. I think the PowerPoint presentation has the slideshow.
I think I am audible and visible both.
Yes.
Yes.
Okay. The first question.
Sir, you can start.
The clinical feature suggestive of malignancy in thyroid. There are 4 options, A, B, C, and D. A is long standing goiter. B, huge thyroid swelling more than 10 centimeter diameter. Hard and fixed thyroid swelling. And D, increased uptake of radioactive iodine than the adjacent thyroid tissue. Should I go to the next one?
Yes, sir.
47-year male with thyroid, female with the thyroid swelling here. Ultrasound, gross aspirate. And this is the cytologist smear. You have to tell the risk of malignancy in this case. A, B, C, and D.
Is the quiz only for the residents? Pranab Da, can I participate?
Yes, yes, why not? But okay, that is just for fun.
Sorry, ma'am, but only attendees can answer the questions.
No, I'm also an attendee, but I'm a speaker.
Third question. This feature, the arrowhead, is frequently seen in A, B, C, and D.
You just saw one such case.
Next, question number 4. Tip of the arrow indicates that is commonly seen in medullary carcinoma, papillary carcinoma, anaplastic, and insular. Question number 5, 60-year-old male had a swelling in the thyroid for a few weeks. This is the cytology picture and the flow cytometry. This is lambda and here kappa expression, CD20 positive, both CD5 and 23 positive. So the case should be labeled in Bethesda as category 2, 3, 4, and 5. So you have to know Bethesda system. Category 2 is benign, 3 atypical AUS, atypical cells of undetermined significance. Category 4, follicular neoplasm. Category 5, suggestive of malignancy. Case 6. What is your diagnosis in this? Cytology along with immunocytochemistry has been given. This is the calcitonin stain. These are the cells. Case 7, a 41-year female has 4 centimeter solitary nodule in the thyroid for 2 months. Arrow indicates some arrangement. Red arrow indicates something in the nucleus. Here also multinucleated cells and optically clear nucleus. What should be advised in this case according to Bethesda system? Or overall, repeat FNAC, A, B, thyroid scan, C, clinical follow-up of the patient, and D, total thyroidectomy. 55-year-old male, old female had solitary 5 centimeter diameter nodule in the right lobe of thyroid for 6 months. This is a cytology picture. Recommended management should be lobectomy, total thyroidectomy, repeat FNAC, or clinical follow-up. This is question number 8. Question number 9. A 36-year female at 3 centimeter diameter swelling in the midline of the neck. She had history of weakness, malaise, pain, and high serum calcium level. The cytology picture along with this histopathology. The diagnosis of this case is difficult for you, but I have given it for follicular neoplasm, medullary carcinoma, parathyroid neoplasm, insular carcinoma. And last one is 61-year female, swelling the thyroid for 2 months. FNAC was done from this nodule. This is the picture. Nuclear structure, this structure. This is the arrangement. Most likely diagnosis: Merkel cell neoplasm, lymphocytic thyroiditis, non-Hodgkin lymphoma, papillary carcinoma of thyroid. This is number 10 and last slide. I think time is over. So should I close it?
Yes, sir.
Okay.
So thank you, sir, for a very challenging quiz. So we will now move on to the next session, that is monologue on the FNAC thyroid by Dr. Pranab Dev, sir. So over to you to continue with the monologue.
I was thinking we will have the monologue first and then the quiz. It happened the reverse order.
No. We always have the quiz first with the answers at the end of the monologue.
And I must admit here that I feel privileged to share a same platform as my guru. Pranab is my guru.
Okay.
So,
Thank
I'm
you.
his first
I'm sure he's
student.
proud of you. I'm sure he's very proud of you.
I'm delighted to be here together with him sharing.
So should I
this
share now? Because
Yes, please.
already.
Yes, please.
Am I visible?
Yes.
And audible also.
Yes, sir.
So, actually, it is a difficult talk because the audience are totally different. I will be as brief as possible here.
Thank you.
And this is the heading which I'll speak. Introduction, approach to FNAC, interpretation of Bethesda system, ancillary test, and summary and conclusion. But the first question is, why to do FNAC? When we have thyroid scan, ultrasound, and you can get the tissue by histopathologic examination. Thing is that thyroid scan and ultrasound are sensitive, but not very specific. And tissue diagnosis is not possible by two-cut biopsy because thyroid is a very vascular organ. So what is the special advantage in thyroid FNC? Thing is that you have not to do any biopsy, which is not possible also. And it's a superficial lesion, easy to do. You can do from any of the OPD. Indications, I have highlighted here some general indications. Thing is that you can send the patient for FNC when there is any palpable nodule of thyroid. And if it is less than 10 millimeter in diameter, with clinical or suspicious feature in ultrasound, and predominantly solid nodule in ultrasound sonograph, and ultrasound guided FNC could be done from the solid area of a cystic nodule. I will discuss in detail which patients you should not send for FNC. Actually, there is no absolute contraindication, but it should be avoided in hemophilic patient or other bleeding disorder. I'll request not to send these patients for FNC because we have a very bad experience on hemophilic patient. And naturally, this clinical history is helpful. Duration, how quickly increasing, toxicity, relevant clinical history, size, consistency, etc. Some of the clinical features are really suspicious for malignancy. I have listed, maybe you all know of them, particularly hoarseness of the voice, hard and fixed nodule, which I have given in the one of the MCQ, and enlarged cervical lymph node. Also, you may have the family history of thyroid malignancy, history of multiple endocrine neoplasia. So these clinical features, when you get, you have to be cautious. Now, these investigations, it is better to have when you are sending the patient for FNC. What are the investigations? One is thyroid hormone level, TSH, T3, T4. When you get high TSH, likely it is less malignant, chances of malignancy less. And thyroid scan, hot nodule are rarely malignant. So your target is that nodule which is cold with low TSH. This will do for FNC. So before FNC, it is better to have thyroid scan. If TSH is low, hot nodule, many people think that there is no need of FNC. If TSH is high, abnormal ultrasound and thyroid scan, FNC can be done. So these are the things: thyroid hormone level, thyroid USG, thyroid scan, preferable you should have. Some of the ultrasound features are very suspicious for malignancy. What are they? Hypoechoic solid nodule. If there is microcalcification, if the nodule has irregular margin, the margin of the nodule is irregular, and there is a nodal sign of nodal metastasis. So these are the features, ultrasound features of malignancy. And this is the ultrasound and non-palpable lesions or low or less dimension, such as this is two committee has given the suggestion: Academy of Clinical Thyroidologists and American Thyroid Association. All of these two associations, they say that if it is more than 20 millimeter, you should go for FNC. That means FNC should be suggested. If 10 to 20 millimeter, and ultrasound features suspicious, then also you can go for FNC. And if less than 10 millimeter, FNC, if clinical risk factor is there. And American Thyroid Association says FNC if clinical risk factor or suspicious features in ultrasound. So basically, more than 20 millimeter you should do. Less than 10 to 20 millimeter, you may or may not do. And less than 10 millimeter, if ultrasound or clinical feature is suspicious, you should send for FNAC. This we must be knowing thyroid imaging reporting system. T-Tyrex. Here they have given points on the basis of composition, echogenicity, shape, margin, and echogenic foci. Each of them I have not elaborated, 0 to 2 points, 0 to 3 points, and then you add the points from all categories. Tyrex 1 and 2, no need of FNAC. Tyrex 3, 4, 5, they may need FNAC. TR5, highly suspicious. So if it is even less than 1 centimeter, you should go for FNAC. TRI4 also moderately suspicious. If it is more than 1.5 centimeter diameter, you should go for FNAC. And this is TRI3, more than 2.5 centimeter diameter, you should go for FNAC. So this is the recent Tyrex committee's report. Now, do you need a consent? No. Pathologists and radiologists usually do not need a formal consent, and informed consent process you may get from the patients. So clinician's duty to get the consent from the patient. In fact, verbal consent also enough in our country, but in outside India, many of the countries are very strict, and you may need full informed consent from the patient before going for FNAC. Now, just 3 minutes video, I'll show how to do the FNAC. So this is the way we do FNSC. After that is the time to interpret the material. So you need a good clinical history, as I have told, examination of the patient, thyroid hormonal status, and thyroid scan, if any. And gross material you have seen in this patient just now. I have done that. That was colloid. So material also gives you a lot of information. Then you examine under microscope, and we go for direct smear, cytospin, cell block. We do for immunocytochemistry, very important. Nowadays we do liquid-based cytology, which may make multiple smear from the lesion. For molecular test, we take the material from the cell block or liquid-based cytology or FNSC directly. This is the WHO's classification. You all know, I will not go for that in detail. Newer Bethesda system is very important of reporting thyroid cytology. Bethesda is there 2008. It came, it published first time. Then there is some modification. The first thing is non-diagnostic or unsatisfactory, number 1. Number 2, category 2 is benign. And these are the entities which come under the benignly. Thyroid TBS or thyroid Bethesda system, benign follicular nodule, adenomatous nodule, lymphocytic thyroiditis. Then come that atypia of undetermined significance or follicular lesion of undetermined significance. Then follicular neoplasm or suspicious for a follicular neoplasm. Category 4, category 5 is suspicious for malignancy, what we are not sure, and then malignant and its subtypes. So again, I am highlighting, it is very important Bethesda system. Risk of malignancy when a cytologist diagnosis is non-diagnostic because of cyst fluid, acellular or other, risk of malignancy 5 to 10%. And here repeat FNSC should be advised. When it is reported by the cytologist as benign in the Bethesda system, risk of malignancy 0 to 3%, which I have given in one of the thyroid which. And clinical and ultrasonograph follow-up is enough. When there is atypia of undetermined significance, risk of malignancy 6 to 18%. And here repeat test, repeat FNSC can be done, molecular testing, and lobectomy is the treatment. Then follicular neoplasm or suspicious for follicular neoplasm, risk of malignancy 10 to 40%. So now it is increasing. Definitive surgery such as lobectomy or hemithyroidectomy can be done. When suspicious for malignancy, risk of malignancy is much higher, 45 to 60%. Here you can go for thyroidectomy. Similarly, malignancy, when cytologist diagnoses malignancy, risk of malignancy is very high, 94 to 96%. Here also treatment, thyroidectomy. Is both these 4 and 6 I have given in the thyroid quiz session. So risk of malignancy may be variable NIFTP means non-invasive follicular thyroid lesion with papillary-like picture. If you consider it is not carcinoma, then risk of malignancy less. But NIFTP, if you consider as malignant, then risk of malignancy is much higher. And here again, I am highlighting that AUS or FLAS, follicular lesion of undetermined significance or atypia of undetermined significance. Here we need molecular test because it will not be useful for you, for the clinician. And clinician may think what to do in this case. Now, as it is not cytology session, I'll be very fast and maybe I will omit some of the slides. I'll show you the Bethesda system, different cases, cyst fluid with abundant macrophages. This is the colloid goiter with cystic degeneration. If no abnormality in USG, ultrasound, repeat FNAC, you can go. If ultrasound shows some abnormality, then you may have to do repeat FNAC. And repeatedly, it comes cystic lesion, ultrasound is abnormal, then you may have to go for excision. This is the colloid goiter, category 2. I will not explain much. We can go for, this is the lymphocytic thyroiditis, category 2. You can see abundant lymphoid cells. The thing is, important thing is that you may get sometimes even grooving, overlapping nucleus and inclusion-like structure, which one of the last number 10 questions I have given in the quiz session. Now, if you see this is category 3, follicular lesion of undetermined significance, multiple follicles, but background also some colloid. You are not sure what to do. Yeah, repetitive microfollicles, thin colloid. So it will come as FLAS, follicular lesion of undetermined significance. Same thing as atypia of undetermined significance. Here also you can see, this has been given in the quiz session. The multiple, you see that cluster of cells, inclusion-like structure, inclusion-like structure, even grooving also. So you are not sure here. So it has been given as, you see that grooving, and category 3. Actually, it came as lymphocytic thyroiditis. Then another category 3 example, where there is architectural abnormality. You see that papillary-like structure, nuclear atypia also there, some amount of overlapping, even this, and it comes as category 3. Now, whenever this category 3, you get the report from the cytologist, then it should be repeated FNAC. You please send the patient again. When you will send, some people think that 3 months to 6 months, but nowadays the suggestion that you should do within few days, because in the American Society they say that don't give the patient intention, and you should have the thyroid scan. If it is cold nodule, then you have to follow up this case and have to do molecular testing. And if molecular testing suggests that it is neoplastic lesion, then you should have lobectomy in this patient. So this is the very important category. That's why I am repeatedly saying in this category and describing this category again and again. This is diagnostic category 4, follicular neoplasms. You see abundant thyroid follicles. And here also I have highlighted that molecular pathology, RAS mutation, 35% cases you may get. It is very difficult or not possible for a cytologist to differentiate follicular adenoma and carcinoma unless you get some metastasis. So this is a case, category 4, oncocytic neoplasm or Hartle cell neoplasm. And so category 4, risk of malignancy, I already told 10 to 40%, and definitive surgery or lobectomy or hemithyroidectomy should be done. This is a non-Hodgkin lymphoma, category 5. Because non-Hodgkin lymphoma, primary NHL, many people think that only on the cytology, it is better to report as category 5. If flow cytometry is suggestive, it may go from category 5 to category 6, if you are very sure with the ancillary test. And category 5, here also another case, is a follicular variant of papillary carcinoma. It is difficult to diagnose, suggestive of carcinoma, thyroid papillary carcinoma. So here also the treatment is lobectomy. Now I will go to this definitive category, category 6, where you will be benefited from the pathologist and cytologist. This is a papillary carcinoma thyroid. I have given in the one of the quiz. This is typical Samoma body, and this is typical internuclear inclusions, pseudo inclusion, very characteristics. Now, I do not want to highlight these things. I can go to the next case. Here, the another variants of papillary carcinoma, oncocytic variants. So I can go to the next one. Here, rate PTC translocation is present in 20% of papillary thyroid carcinoma and BRAF genetic mutation in 50%. So you can have this molecular test in AUS or in follicular lesion or category 3 or 4, and here you may get the indication for surgery. So again, I am omitting this slide. This is a typical medullary carcinoma of thyroid, category 6. I go to the next. This is the features of medullary carcinoma, positive for calcitonin, which I have given in the quiz session. This is the tumor develops from the C cells of parafollicular cells of thyroid. So they are positive for calcitonin, and I will omit this. This is an insular carcinoma. This is also very characteristic. This is a histopathology. For cytologists, it is sometimes difficult of insular carcinoma, and this category 6. So I'll omit this slide again. And this is the anaplastic carcinoma, which is very easy for diagnosis from the cytopathology section. And this is the anaplastic carcinoma features, which we do not want to discuss much. Sometimes you may get metastasis, and sometimes clinicians send to us a patient diagnosed as carcinoma based in this patient, and there was a swelling in the thyroid. So we can say that it is metastasis or not. Even you can have cell block and other immunocytological markers you can do. And so risk of malignancy 99% you can say, and thyroidectomy or definitive treatment can be done. Rarely we face this type of rare tumor, Langerhans cell histiocytosis of thyroid. This is a young female has this type of lesion, which is very difficult for cytologists until and unless you know the history in details. I have given in the quiz session. It was a case of Parathyroid Neoplasm, and we could not diagnose it. It comes at category 3 or 4 when cytologists are reporting, and expert cytologists with full history you can give category 5. So immunocytochemistry not helpful in cytology, except calcitonin can be helpful. Galectin, people demand that galectin is very helpful, but it is really not very helpful in differentiating this follicular carcinoma or adenoma, because sensitivity is much low. And now molecular test I have already told how to collect. These are the molecular tests. I will not go in details, but next generation RNA sequencing, Apharma GSC, this may help you. If the tests are negative, then you can omit surgery. But if so, it may help to some extent to detect your cases, which one you go for surgery. Now, accuracy, diagnostic accuracy of FNS is very high. In fact, sensitivity may be a bit low, but if you do ultrasound guided FNSC, you will have much more sensitivity. Specificity is quite high. And in conclusion, I can say that thyroid scan and ultrasound are helpful guide. Thorough clinical history is always needed, and clinicians' importance very high here. Bethesda system, clinicians should know the Bethesda system classification. It is the very helpful system. It can guide you properly, and molecular testing may be helpful in atopy of undetermined significance cases and follicular neoplasm cases to say whether the patient should go for surgery or not. Thank you very much, and thanks to all of my audience for your patience, because I have taken extra 4-5 minutes time. Thank you.
Thank you, sir, for a very explicit talk. So, sir, there are a few questions in the chat box.
Yes, yes.
Dr. Sagar has asked whether PT-INR is necessary before FNAC.
PTI. Actually, if there is no bleeding history, so PTI is not necessary. We do a lot of thyroid FNAC. Every OPD, at least 20 cases we do. And we do not have PTI, PTTK or anything. But if there is history of hemophilia, particularly I do not do. I will recommend not to do. So PTI is not needed. Okay. Any other question?
Sir, Dr. Arpan sir has asked regarding the ultrasound guided FNAC thyroid.
Ultrasound guided FNAC criteria? Yes. In fact, in a single sentence, there is no criteria. If clinicians feel they can go for ultrasound guidance, in fact, that is written or it's a known facts. But if it is not palpable, that means less than 1 centimeter, sub-centimeter, one can go. Number one. Number two, if repeated FNAC failure, you are not getting the material, you can go for ultrasound guidance. Number three, if there is a cystic lesion and you think that their ultrasound is solid area or any cystic lesion, one can, in some of the countries which I have worked, they go for ultrasound guidance FNAC from the solid area. So these are the main criteria, but there is no criteria actually. If clinician feels that it should go for ultrasound guidance, they can send it.
So one last question. So Dr. Neelam has asked, what are the chances of having a worrisome histologic alterations after FNAC of the thyroid? If we repeat the FNAC in the immediate period, and
yes, this is a very good question. And the person who can have the answer, she's smiling here. May I request Uma to say, because she faces a lot of, when after FNAC we are doing, she faces this problem.
Yes, sir. So thank you, Pranab Da. Well, sometimes we do see a lot of infarction, especially when the surgery is done within a short span after FNAC. Then hemorrhages are a common finding. Sometimes even hemocyanin macrophages and fibrosis. And the morphology also gets altered sometimes. So, like if you are gentle, like Pranab showed, the needle, the negative section technique, that's very useful. And I learned it in my residency days, this technique from him. And I still practice it if I have to do. And I always recommend everyone to go to him because it's less painful. And unfortunately, I have myself undergone a thyroid FNAC. So I know how painful that is. So the needle suction technique with only the needle, not using the handle, that's less traumatic. But if you're using a big needle,
Right.
21B with the handle, that's more traumatic. So
Right.
we do get to see these changes. Yeah.
Yeah, thank you, Uma. Actually, fine needle sampling, I have shown, deliberately I have shown that video, and
Right.
patient doesn't know even that when the FNAC is done.
Right.
Because it is so
I agree.
less painful, so abundant material. I have shown you that it is giving more material than the first FNAC I have done in the video.
And it is less scary. That handle scares the patient.
Right. Less scary, and thyroid is very vascular, so it is preferred. We should do fine needle sampling. Any other?
Was it light to see all those cases and all that material which Pranab has collected over a period of time? And I again say that I really feel proud and privileged to share the same platform as my Guruji. Thank you, Dr. Sarita and the entire team of ITS. Thank you so much.
Thank you, ma'am. Ma'am, a few
Thank you for the
questions
great
from,
compliments.
CPC also were not answered. So I request Unikrishna, Mala ma'am and Uma ma'am to answer these questions. So Dr. Pooja has asked, should we prefer the cardioselective beta blockers than propranolol in order to prevent failure or arrhythmias under the cover of anticoagulation? So because the patient is having arrhythmia and has a predisposition for developing thrombus. So Unikrishnan sir, Mala ma'am, your comments regarding the same.
Definitely, I feel that a cardioselective beta blocker can be used, but we also use non-specific beta blockers also. But in this particular patient, maybe that would have been much better. Of course, what was the second part of your question?
Under the cover of anticoagulation, ma'am.
Yes.
Yeah.
So again, we don't know he has cardiomyopathy. No, that came out only later. So why would we do an anticoagulation on a routine? So that is something I would be worried about. But yes.
Dr. Arpan sir. Yes. Dr. Arpan sir has asked another question, whether pneumonia was the precipitating factor for the thyroid storm. So, ma'am and sir, your comments regarding the same.
I would think so. If you look at that, cardiomyopathy must have been there for a long time because it's a chronic process, and that pneumonia would have been the precipitant for the thyroid storm. Do you agree, Unni?
Yes, I completely agree. It's a likely, unless there is some information that can be added, I think pneumonia is a possible underlying cause, definitely.
I would say here something that the pneumonia might have aggravated the thyroid storm, but that's not the cause because the pneumonia was terminal and the inflammation was just maybe around, you can say, 24 hours to 48 hours duration. It was not more than that. So there were areas of alveolar hemorrhage accompanied with inflammation. So it was within 1 to 2 days duration, not more than that.
Well, actually, thyroid storm doesn't need a much prolonged, precipitation. There are even cases of palpation thyroiditis where medical students have palpated the gland for a few minutes and precipitated thyroid storm. So even a very minor infection can precipitate it in highly predisposed people. But your point is well taken, Dr. Uma.
And also when Dr. presented, he said right in the beginning that there was a pneumonic patch in the lung. So then, and the patient went into thyroid storm. Otherwise, there is for me like what could, he's a young guy, 36 years, what could have just pushed him into this thyroid? He came with periodic paralysis, common enough, but also having thyroid storm, maybe just a little bit of infection with a high blood TLC count could have been the precipitating factor. Some infection.
So,
as Dr. Kotwal discussed, the score which he showed for the thyroid storm was borderline, impending storm. And then as Dr. Unni is highlighting that when pneumonia occurred, so it got precipitated and it aggravated it.
True, absolutely.
I would put it like that, yeah.
Yes. So thank you, Dr. Mala, Dr. Unikrishnan sir, and Dr. Uma ma'am for answering the questions. So I now request Dr. Pranab Dev sir to share the answers for the quiz questions.
So we can leave now, right? I know the answers.
Yes, you can definitely leave, Dr. Uma.
Thank you so much, everyone, and a very good night to all. It was indeed enjoyable for being being a part of this session and this ITS community. Wish to see you all again soon, maybe physically, not virtually. Thank you once again.
Thank you.
Thank you.
Thank you.
Am I visible?
Yes, you're visible and your slides are well seen. Please go ahead.
So now I'll quickly show you that answer. First question, you may know the answer after the lecture. First is hard and fixed thyroid swelling is the most important clinical feature for malignancy. And this is a colloid goiter where the risk of malignancy after the reporting is that 1 to 2% still chance that this may be malignant. This is a colloid goiter. This is a typical fire flare appearance. You can see the fire. And this is typical picture of Graves' disease. Fire flare appearance, people think that it is related with thyrotoxicosis. Then people used to believe that it is not, but I have seen that. And this is the most frequently seen. That's why I have written. It may be seen in other tumor conditions, but Graves' disease most frequently you see fire flare. So answer will be A. This is I have shown you typical Samoma bodies. You can see the concentric calcification in the FNSC material. So commonly seen in papillary carcinoma. This I have shown you during discussion, and you can see that light chain restriction, only lambda chain is expressed. CD5 and 23 both positive. Actually, it is a small lymphocytic lymphoma, SLL, and it should be category 5. Answer D. D. What is your diagnosis? It is very easy. Now you know that I have shown you that slides in the lecture session. This is calcitonin positive, and it is a medullary carcinoma thyroid. Typical cytologic picture. It is very difficult. That's why I have given that calcitonin. Papillary carcinoma, you must be knowing now, this is papillary carcinoma, and its treatment is not repeat FNSC thyroid scan or clinical follow-up. When cytologists saying that it's Bethesda system type 6, category 6, it should have total thyroidectomy. This is a follicular neoplasm, and lobectomy is the standard treatment management. This I have shown you. This is actually a parathyroid. It's very difficult, but that's why I have given the cytology. And I have shown you this picture in this lecture session. This C, parathyroid neoplasm. It's very difficult in cytology, and it is not fitting with any other lesions of thyroid. That is in other way people diagnose it. But when the serum level, calcium level is high, you should be suspicious for parathyroid neoplasm. And number 10 is very difficult slide. You can see the background lymphoid cells and inclusions, grooving. This misguided you, may misguide you. Actually, this has misguided me during reporting. It's a case of lymphocytic thyroiditis, not papillary carcinoma. Lymphocytic thyroiditis, occasionally you may get this type of things. It's very difficult for you for diagnosis, and this you must be knowing. Okay, thank you very much.
Thank you, sir. Sir, I now request you to announce the winners of the quiz. The IT team, if you can display the winners. Sir, I request you to announce the quiz winners.
So these are the winners. I'll say that Dr.
Yes.
Nevin S, Dr. R. Manoj Kumar Reddy, and Dr. Anil Kumari. So I think they have got the highest marks.
So,
Thanks to all these three doctors. And it's very difficult for the clinicians, I agree that. So I especially congratulate you. And I am thankful to you that you have joined in the quiz session. Thanks to all of you.
so we request the winners to enter their full names and email IDs in the chat box. I now request our eminent chairperson, Dr. Mala Madam, to deliver a few words.
Thank you, Dr. Ganavi. I think this session was really very enlightening, and we had excellent CPC by Dr. Kotwal and Dr. Uma. And then, of course, we had a very good session on FNAC. For us as clinicians, as Doctor has pointed out, it is always very difficult to look at histopathology or an FNAC to understand very clearly where we are. And I think the more I look at it, the more confused I get about it. But it was really nice, and it took me back to my DM days where I looked at all those slides. Thank you, sir, for that. And I think it was a wonderful presentation on the whole. So back to you.
Thank you, ma'am. I request Dr. Krishnan sir to give his comments.
I think it was a wonderful session, like Dr. Mala Dharmalingam madam said. I truly enjoyed the deliberations and interacted with the interaction with the endocrine community and the pathologists. I think the endocrinologists and the physicians learned a little more about pathology, and I hope the pathologists also enjoyed the endocrine and medical interactions. Wonderful event.
Thank you, sir. So I now request Dr. Arun Menon sir to give his closing remarks.
Good evening, Ganvi. So please go ahead. I think I have nothing much to add. Thank you, Unni. Thank you, Mala ma'am. Thank you, both speakers. In fact, I really enjoyed the CPC and Dr. Day's quiz, as well as the his session on the FNA, or his talk on the FNA, were really very nice. So thank you so much. Ganvi, you can conclude the meeting.
Yes.
Thank you.
So in the next session of the thyroid clinics, that is on 3rd August, we have Dr. Sunil Mishra sir as the chairperson, Dr. Nisha Bhavani ma'am as the moderator. So we have 2 journal articles to be presented that week. This is followed by the quiz by Dr. Tejal and monologue by Dr. Alka Singhal on the case-based review of thyroid ultrasound. So thank you one and all for your active participation. We request your active participation in the following thyroid clinics as well. Thank you all. Stay healthy, stay safe. Thank you.
Thank you all.